Alrighty, it is 12 o'clock on the dot, so we can go ahead and get started. Welcome everyone to Collegial Conversations with Diana Clark. Today's topic is the role of relationship-centered care. Thank you for joining us. And with 5 minutes left in the webinar, we will open the chat for questions. So please feel free to ask any questions using the Q&A function. Diana, I will pass it over to you.
Thank you, Brandy. I am thrilled today to have a guest that I have listened to his podcast, seen him talk at conferences, heard about his work, read his book about mental health. His name is Virgil Stucker. Many of you have probably heard of him, but what he has done is be a pioneer in the field where prior to the work that Virgil and his people and his followers and his community taught was that the therapeutic relationship had this boundary between us, right? We were the experts and they were the patients. How did you and your philosophy flip that?
Oh, philosophy. That's one of my hot buttons, Diana, since I'm a philosophy major.
Okay.
Okay.
Let me know.
Yeah, so actually, early on in my study of philosophy, I became fascinated by the study of metaphysics. It's like, what is the fundamental building block of reality? And I don't think we're like little atoms bouncing around on this billiard table of life, right? We're not objects. We don't have the fixers and the fixed. The fundamental building block of reality is, in fact, relationship, and it's all in process. So as far as, quote, flipping it, my experience in this world of therapeutic community, which is all about relationships, began way back in 1975. Okay, so I go back a ways, right? At a place called Gould Farm in Western Massachusetts, where I saw, lived, found the value of relationship. I mean, relationship is not like the sole solution for mental health challenges. And pause for a moment, thinking about mental illness. Mental illness is really a relationship illness. It's a process of mental dis-ease. We become disengaged from the world, from ourselves. People who experience psychosis even sort of experience parts of themselves that they don't recognize anymore. They're not in relationship. So that's why it's important, I think, for any mental health healing process to occur within a therapeutic milieu that pays attention to the relationship. Yes, we need the best of mental health science. We need the best psychotherapy, the best psychopharmacology, the best, neuroscience, but none of it actually works as well unless it's delivered within a therapeutic milieu that pays attention to relationships. So as far as how I flipped it, I guess that's how I've always sort of, well, not always. It took a while. I mean, I remember once being lost in the study of Jean-Paul Sartre, the play No Exit.
Yeah, sure.
It's like, that was such a dismal sort of experience, not finding there was actually a path to full engagement and full life with other people. It's like he's saying there's no exit from, the tyranny, the imprisonment that occurs in relationships. That was not my experience. And a seminal book, you're asking when I flipped. There's a book called Zen and the Art of Motorcycle Maintenance.
Yes.
Yeah, Robert Pirsig, who himself had experiences with psychosis and went on this journey across country where his son sort of literally helped put him back together through relationship. That was one of my seminal sort of awarenesses that no, relationship is so critically important, and our mental health care, the way we treat people has to pay so much attention to relationship. So it's fundamental. So that's my answer to your question.
I 100% agree with you. I don't do therapy. I did get a degree as a master's in therapeutic counseling and don't do therapy in part because the model I was taught was so much more, I am the expert, I am the neutral professional, and I didn't believe in some ways that being authentic, expressing, wow, That must hurt because I hurt.
Oh, the empathetic sort of reaction that you just described. I mean, I I lament the fact that in some sort of therapeutic experiences, the therapist has to shut that down.
Yeah.
And it closes the door to some authenticity because it doesn't let you be all of who you are in that moment, which is a healing expression, not the opposite. So,
Exactly. And neuroscience is sort of catching up to that, right? What we know about the amygdala, that flight, fight,
mhm.
freeze center, when two people connect authentically, it calms that down.
Yeah,
For
yeah,
both,
no. So,
that makes sense to me. That's relationship centered care.
and again, the disconnection, mental illness is mental dis-ease, disengagement, detachment. So why wouldn't we talk about relationship-centered care? Without it, I'm not sure we really have full care. So,
Right. I agree. I agree. I agree. So let's go back. You have had lots of positions in nonprofits in developing relationship centered care. What's your favorite experience when you think of a person who came into your any practice in any one of those realms that seemed really in dis-ease
mhm.
that you connected with that shifted things for you? Yeah.
Um, so you're what's coming to mind is an experience I had with a resident at a therapeutic community. And I've had some experiences with Gould Farm, as I mentioned, and then was able to try and replicate it essentially in 3 other places. But you're reminding me of an experience at Gould Farm. I'm on a hillside. There's a resident who had been in extreme distress, came from a hospital, had knew for sure what her diagnosis was, didn't know though how she could re-engage with the world.
Mhm.
And after about a couple of weeks in this therapeutic community, this nurturing, sort of supportive place where people were asking her not just what her diagnosis was, but what her dream was, she was starting to realize that, she was more of a person than just a patient. And so she's on this hillside, and I'm seeing a smile for the first time in my experience with her. There are birds flying above. There's a breeze that you could feel on our cheeks. And she said, I feel at home. I feel a sense of belonging. And I can see a future. So, in that moment, as a result of being in this therapeutic community, she had reached this point of integration instead of disintegration. And it took that full community experience, not just sitting in an office and talking about her symptoms, but the full life of this therapeutic community inside of a 2-week time period gave her that fundamental integrating experience. That's coming back to me as you're asking that question after goodness, 40 years. Okay. And I've
It's
seen that over and
full
over. I've seen
story.
it.
Yeah.
Some people worry about relationship-centered care if they're a provider or a professional. They worry that, oh, if I open up and get too close, how will that, can I bear that burden? And I've spent, a few thousand people. I've gotten close with a few thousand people in this journey of helping to create therapeutic communities, and it opens you up.
Mhm.
And I've been asked, well, how do you manage that? How do you manage the quote emotional burden of that?
Yeah.
And what I say to that, Diana, is most often the emotion is one of joy. Yes, sometimes pain, but imagine, being absent, of joy and pain in the experience. What do I want? Indifference? No, I mean, intellectual, satisfaction. It needs to be more than that. As the provider, I want to have that full experience, the full emotional experience where I can experience that joy. And I think when I approach it that way, yes, you do have pain now and then, but the joy is far more prevalent. So this does open the provider, I think, to even more energy, not less.
I agree with you. I do agree with you.
Mhm.
Opening up to somebody else's experience allows us to get the richness of their lives in addition to ours. So
Yes,
sometimes that is painful. You're right. And sometimes we have to sit next to people in pain without fixing it, without shaping it, without just being next to them. That's the relational element.
right. And being next to them, sort of being on the journey with them. Like early on, I remember the director of Gould Farm saying, Virgil, that's where we are. We walk with, we dine with, we recreate with, we work with people in relationship. So yes, that's part of it. You're a sojourner. But this is bringing to mind too, the questions are so important for us as providers to ask. I mean, yes, we have to pay attention to diagnoses, the symptoms that go with that. And part of what we're doing is help to reduce the impact of those symptoms so the person has fewer impediments and can flow forward. But in what direction? To what? What I have found over and over is no matter how sick the person is, ask them what their dream is, not just what their diagnosis is, literally. And you'll get people that, oh, my dream? I haven't been asked that in a long time. People ask, what's my diagnosis? But even the most psychotic individual, you ask them what their dream is, it puts them in a different place. You'll find their voice often strengthening as they, sometimes they'll say, Virgil, I don't know. And I say, well, that's okay. Be in the therapeutic community for a while, start to experience yourself in your brain again as someone
And
who has
safety,
capacity,
right?
right, who's safe,
Safety. Yeah.
right? And, people, they start to dream again. And that, any treatment plan needs to have two questions. One at the top is, what is your diagnosis, symptoms, who's doing what, when, to help ameliorate those symptoms. But the other side of the treatment plan literally needs to start with, what is your dream? What is your core goal?
Aspirations. Who do you want to be? Yeah.
Right, exactly. Because if we could, make all the symptoms disappear tomorrow, people still need to know what their dream is. And
And a lot of people, don't you find that a lot of people have been in survival mode? They haven't had the safety
right,
to look at that dream in a very long
right.
time by the
Or
time.
to be seen as someone who can even have a dream.
Yeah.
Sometimes we think as professionals, oh, we have to get this person's mental illness under control and their symptoms under control before they can actually start to live again. So hold on. If you can tap into that dream, that helps pull them forward into this awareness that they can be strong again. And it already then starts to help develop resilience for them. Because our research has shown that when people are recovering, three things occur. They tell us, and this is through 10 years of research looking at exit data and doing qualitative analysis in the last therapeutic community that I helped found, a therapeutic community called Cooper Reefs. So we learned from the residents, they reestablished a sense of belonging in the world. Not separateness, not disconnectedness, but belonging. I have a place in the world. Secondly, a sense of purpose. Why? Because everyone developed a dream statement, not just a diagnostic statement. And then thirdly, resilience. And think of, resilience, we have to have ways of envisioning a better future, a better way of being in order to be resilient. When we're knocked down, we have to be able to see that, we can move forward.
And make meaning out of that struggle, right? Part of
Right,
resilience is making meaning, I think.
right. Yeah, it is. And, finding that meaning, if someone is in the midst of, a very, acute, chaotic process, and I say, well, what is your dream? And they say, well, I don't know. Well, I say, well, let's go and do some work together. like in these therapeutic communities, we would have gardens and wood shops and kitchens, basic sort of work that people would share with. They would get up into a day where they were needed, and they would go out, and even though we weren't training them to be gardeners, et cetera, it would get that part of the brain going where it's like, oh, I can start to think about strengths and capacity. And the next time you ask them about, what is your dream? I remember this one guy said, while I was out there pulling the carrots, I remembered that I had learned Mandarin and I want to learn even more so I can become a translator. I was like, okay, that's an interesting discovery in the garden. But that part of the brain otherwise too often lies dormant when you're just dealing with, your symptoms. You're trying to develop, and that's important work too. But it's only half the picture. I'm not even sure that it's half.
I don't think it's half the picture. I think it's a part of the picture.
Yeah.
So when I think of case management, or when I think of supporting somebody, I think of a whole bunch of buckets. How are they doing relationally? How are they doing with their purpose? How are they doing with their emotional health? How are they doing with their physical? I mean, it's all one part, right?
Yes. And that sense of meaning and a sense of purpose. Sometimes people will say to me, Diana, well, what if someone says they want to become a psychiatrist or a lawyer?
God forbid. That's
Yeah.
my old job.
or a psychotherapist. They said, is that realistic? I said, what? You want me to step on their dreams? Well, is it realistic? What you want me to say they have no hope? No, you never, ever step on someone's dream. Now, as they're going for the dream and they break it down into goals and objectives, that may change over time. But I have known people who have had profound psychosis and have become physicians who've gone on to get a PhD. One young man who's a close friend now had multiple challenges, had multiple experiences with therapy, etc., was so depressed, and now he's just completing his PhD in clinical psychology.
I love that story. My dad has and is medicated for bipolar disorder, and he's had some very serious breakthrough depressions where ECT, or electroconvulsive therapy, was part of his treatment. And he was dean of Yale Medical School. He is a very high functioning man who struggles with and is very open about his struggle, because he wants people to know it's not all the human is the diagnosis. He isn't manic depressive. He has bipolar disorder.
Right.
It's part of who he is. Yeah.
Yeah, absolutely. So, yeah, I have had wonderful experiences and multiple therapeutic community experiences. And I stand by this firmly that,
So before we started today, you showed me a matrix of how to make a therapeutic community, or at least evaluate whether your community is safe. And I looked at that and I thought, fascinating, even for our company. How do we create safety so that people can be well, right?
okay.
Would you be willing to share that here?
Yeah, let me bring this up. I call it the Healing Community Matrix. There, do we see it on the screen?
I see it.
So I love giving this away to whomever would like to use it. And everything you need to know about it is on this one page.
We will post this.
So, basically what this distills are sort of 5 key elements of any therapeutic community. And, therapeutic community does not need to be a Gould farm or a Cooper Reese. It can be a system without walls. It can also be a congregation. It can be, I have worked with NAMI groups on this, various hospital groups. So what you do as a group, and I've done this with as many as 100 people at a time, you ask each person anonymously to, say how they feel as far as emotional and physical safety, unsatisfactory, superior. Do they have a sense of belonging and purpose within the community that you're observing? kindness and respect. Is that, someone once asked me, Diana, well, what is kindness? And I said, well, you sure know when you don't have it, right? And actually with Gould Farm, the therapeutic community that's really the oldest in the country, back in 1955, they were studied by the University of Chicago Social Work School. And the distillation of the study ended up saying, well, it has an atmosphere of kindness. That is the most important thing. So kindness is important, one sense of participation, also the capacity for empathy. So these 5 attributes, you ask the entire group anonymously, and I'll do this sometimes with both patients and the professionals at the same time. Everyone's in the community. Because as providers, we need to experience all of this too. So we're all part of that community, that therapeutic milieu. So like when I would run these various therapeutic communities, once a year, I would ask everyone to gather and fill out this matrix. And then, and I won't get into reading all of this, but any of your viewers can download it, I think, when you're finished with this. So you have an appreciative dialogue with the group. You aggregate the data, put it up on a screen and say, well, emotional safety, let's see, we're about a 3.5 on average. Why is that better than average? You always start out on the positive.
Okay.
And then what happens is people say, we can do better. Or you notice down on the bottom, you have a couple of people who said, well, I really don't feel safe. Then you have to say, well, okay, I'm not asking who those people are, but who can help those people? Then people have their hands go up. Well, they can come to me. They can come to me. Everyone, no one is going to look at this and say, hey, let's have less safety. Let's have a less sense of
be unkind, right?
Right. So it all goes into a positive direction, and you do this with any group. I guarantee that the therapeutic milieu within the group becomes stronger. I did this once at the state hospital in Oregon where Cuckoo's Nest was filmed. It was 50 patients and 50 of the staff. And they got so excited about this that frankly, they scored pretty low across these 5. And they said, we can do better. And then about 2 years later, they were still working on their committees. There was a committee that formed for each to improve safety, to improve sense of belonging and purpose. Diana, we all want relationship. We all want to be in a therapeutic, a healing community. You should do, we could do this in high schools.
Could we do it in families? I look at these categories and I'm like, this applies to any family too. Is it safe? Is it kind? Is it respectful? Can you find your purpose there?
Yeah, I have done this actually with family groups, where there was like, we don't know what's going on. We got to figure this out. Mm-hmm. But instead of diagnosing the family, so to speak.
Yeah, let's just look at the functioning.
Yeah. Let's build on the positive. And then you always discover the challenges or the negatives. That doesn't go away. Right. But if you use what's called appreciative inquiry, right, start out in that direction, and you guess what? When you build on the positive, sometimes those things that aren't so positive start to go away.
I like it.
So I'm happy to share this with whoever might find value. And again, this can be in any setting.
Our producer will make sure this gets posted with the video somehow, some way. I don't know how that works, but she will do that.
Okay,
and I
very
think
good.
we could take some questions now if anybody has any. All right, I have a question. As a practicing professional in this field, where do you put the discussion of boundaries, right? What do you share about your experience that doesn't actually cross into, what's your rule of thumb that you're not violating boundaries when you're doing relational?
You have a role definition. In my roles, I have been provider, not receiver. Exactly. So I have to be careful not to use the relationship in some way, to really be about my issues, my challenges.
Got it.
With that said, I've been open with people, like even in leading some of the communities that I've had experience with. I've been open. I mean, in my past, I've had an experience where I had PTSD. I had to have treatment for that. It was a depressing experience.
Yeah.
I'm able to share that I'm a whole human being as well and impacted by challenges.
Exactly.
So, I've found the right time to share that without sharing it in a way that is about me. You always have to keep the role definition. Like, in training staff, I would always train staff to be open when their openness could be helpful, but to realize they're the staff and the resident is the patient or receiver.
Right.
But another key factor in that relationship, by the way, is, and I would train staff specifically to do this, as we listen to the needs of other people and also discover their strengths, our job is to believe in others, sometimes even when they might not fully believe in themselves.
I love
And
that.
there you can use personal examples from your own life where, I was able to, believe in myself, but, I see where you are. I see where you could be. I believe in you. That expression of belief is empowering, not disempowering.
100%. It looks like
And
we have
we do have a question from
okay.
the audience members. I'm going to allow her to speak now.
Okay. Hello, Kate Callahan. You're on mute, so we can't hear you, but love to hear your question.
Hey, oh, perfect. This is great. It's like, how do I do this thing? First off, Diana, I absolutely love the heart tapestry behind you. I want to know where you got that, but later. Virgil, it was absolutely wonderful to hear you. I'm familiar with the Gould Farm, and I've had some individuals that I've worked with who have gone there and also come from there.
Mhm.
I was wondering, you've mentioned this a few times about what types of things that you train your staff on. I'm wondering, as a semi-new clinician, most of my work had been in, it's community-based, as a dual diagnosis clinician, a geriatric care manager in the Boston area, and now with my license, trying to get to my LI, basically. Any suggestions on ways for me to either become a better clinician, have the opportunity to either work in one of the communities you've created, or just even, I don't know, just even suggestions to kind of maybe have
More exposure, more experience, more participation in communities like that? Is that what you're asking?
One thing that I would offer, Kate, is it Kate?
Yes.
Kate. So, first of all, I really like this sort of question and curiosity you have. There is a group that I was a small part of in helping to form 25, 30 years ago now, called ARTA, American Residential Treatment Association, ARTAUSA.org. And it includes the places where I was also founding executive director, Cooper Rees, Gateway, Rose Hill Center in Michigan. But if you look at that group, and you would say, well, I'd like to know more about this one or that one, I'm happy to introduce you. One clinician that approached me with a question like this once, I helped set up a tour for her so that she could experience these places. And as far as, like being a therapist in one of these communities, that can be a very enriching experience. So I encourage you to look at them for that possibility. But as far as training goes, like I said, the training that we would offer staff would be to sort of an empowerment training that is aimed toward recovery, believing in recovery. And that doesn't mean cure. That means helping people get to their highest levels of functioning and fulfillment. So believing in them, giving them not just mental health science, but this whole therapeutic milieu and a comprehensive approach, including nutritional support, as well as psychopharmacy, psychopharmacology, psychotherapy, et cetera. So, and, you know, different communities have different levels of sort of in depth of the clinical or the mental health science side, but I'm happy to have a follow-up conversation with you if there are other places you would like to know more about.
I would love to. I quick other question. I'm sure there's tons of other people, but I did some training with I'm not sure if you're familiar with like Wolfensberg and social role valorization. And a lot of the stuff that you were talking about as far as like having a purpose and giving somebody a purpose and how that, and at that point, this was more, I was working with a lot of individuals with developmental disabilities, some mental health. And I found, because I was a shared living provider, how uh, how much of a life changer that was for people that have always been told, you know, you're this, you're that, you can't do this, you can't accomplish that, to just kind of opening up of, well, what do you want to do? And just that small, it started out as small, but just how that completely changes somebody, you know, and anyways, it's great to hear you. I'm going to shut up.
Well, opening up and, you know, actually Diana showed I tried to put almost everything I know into a little 102-page book recently that is about mental health recovery.
Yes.
And it includes a lot of this thinking of not only relationship-centered care, but, you know, recovery and how families also play a role in that.
Okay, thank you so much.
Thank you, Kate. Brandy, have we called time?
I think it is time. We have reached our 30 minutes.
Well,
All right. I want to thank you, Virgil. This was a great conversation. It's exactly why I do this particular webinar series. I love to hear from people who have experience in all kinds of ways, and yours is critical for every other experience we're going to have therapeutically. So thank you.
Well, thank you so much for the invitation, Diana. And thank you, Brandy, for doing all the logistics and connecting us. And good luck in law school and University of Miami.
Thank you so much.
Yeah.